Hello, everyone. My name is Kota Iwahashi, and I'm the president of AKTA, a community-based organization in Japan. I'm very happy to be able to talk to you today. Today, I would like to share with you the current status and the future outlook of CRM in Japan. As for my conflict of interest, please refer to the disclosure of this slide. Let me start with a brief introduction of our organization, AKTA. Since 2003, we have operated a community center in Shinjuku Nichome town, known as the largest LGBTQ+ district in Asia. Our focus has been on improving sexual health and HIV prevention, especially for MSM and other sexual minorities. Now, let's define CRM. As outlined by UNAIDS and in the CRM of HIV Services Toolkit by Health Equity Matters, CRM is a community-owned and community-led process that aims to improve HIV services. It focuses on key populations and people living with HIV, with the ultimate goal of ensuring accessible, high-quality care and support. So, how is CRM being implemented in Japan? Unfortunately, Japan does not yet have a government budget or institutional framework to support CRM. And CRM is not yet integrated into national HIV policy. However, there are promising grassroots efforts. CBOs have been implementing practices aligned with the CRM approach, and there are ongoing efforts to institutionalize these models. In this presentation, I will highlight some of those community-led efforts in research and advocacy, and explore how they may lead to broader implementation of CRM. Let me provide a bit of context regarding the epidemiological situation of HIV in Japan. Each year, around 1,000 people are newly diagnosed with HIV. The trend is gradually declined, which is encouraging. However, over 30% of new reported cases are diagnosed at a late stage. This is a remarkably high percentage compared to other high-income countries. Let's now look at Japan's progress towards the 95-95-95 goals. The estimated first 95 diagnosis rate is 19.3%. In urban area like Tokyo, the rate exceeded 90%. But in rural regions, diagnosis trends to be delayed. The second 95, access to treatment, is 94.5%. And the third 95, viral suppression, is estimated at 90.6%. These are strong numbers, but early diagnosis remains a serious challenge. To truly end the HIV epidemic in Japan, we need to adopt a person-centered status-neutral approach. This slide was kindly shared by Dr. Nitaya from IHRI in Thailand. In Japan, key challenges include insufficient access to HIV testing, lack of a public system to ensure access to PrEP, delays in initiating antiretroviral treatment after diagnosis, and persistent stigma related to HIV, both in healthcare and society. Let's now look at how CRM-like practices are taking shape in Japan. These include regular outreach to key population, community-led data collection or research, and two-way communication between communities and service providers. However, the reality is that CBOs in Japan operate with very limited resources. There are let me illustrate this by talking about community centers. There are 6 such centers nationwide, including AKTA. These are funded by Japan's Ministry of Health, Labor, and Welfare, but the government budget allows for just 6 full-time staff for community centers across the entire country. As a result, most of the activities rely heavily on volunteers, making the system quite fragile. Now, I would like to introduce 3 case studies from Japan that demonstrate a CRM principle in action. The first is about improving access to HIV testing for MSM. Community surveys showed that MSM often avoid testing because of limited access and fear of having to disclose their sexuality at testing site. In response, CBOs partnered with local public health centers to provide LGBT sensitivity training to staff. Facilities that completed the training received a certification badge, which was then promoted actively through social media and outreach. To reach individuals who still find it difficult to access testing, free mailing HIV testing kits are also distributed through community centers nationwide. More recently, CBOs have begun partnering with national drugstore chains to pilot the installation of digital dispensers that aim to distribute mailing HIV testing kits anonymously and conveniently. While HIV self-testing kits are not yet approved in Japan, CBOs are also actively advocating for their regulatory approval as part of broader efforts to expand access to testing. The second case study is about PrEP access in Japan. In 2024, PrEP was finally approved by Japan's regulatory authorities, a milestone achieved largely thanks to sustained community advocacy. However, there is still no public subsidy system in place. Therefore, in order to use PrEP, individuals must pay out of pocket around $450 for branded Truvada, or approximately $40 even for generics per bottle. According to a 2023 survey in Shinjuku Nichome, only 14.3% of MSM were using PrEP at that time. Nationwide surveys have revealed large disparities in PrEP access depending on income and geographic location. In response, CBOs have advocated for national research on PrEP access and launched petition campaigns to demand public funding. Meanwhile, many people import generic PrEP from overseas due to lack of support, often without any medical monitoring. Survey data showed that over over 40% of users are not under regular medical supervision. Another 7.9% said they want to be monitored but can't find suitable clinic. To address this, CBOs have developed community guidelines and launched educational campaigns to raise awareness about the importance of routine testing and medical oversight. The third case study involves people living with HIV through the Future Japan project. Based on a model from Australia, Future Japan has conducted 4 rounds of surveys so far. These surveys assess the lived experiences of people living with HIV in terms of health treatment and quality of life. One of the key challenges in Japan is that art is often delayed due to the time it takes to obtain officially disability certification, which is required to receive financial assistance for HIV treatment. This chart shows the time from diagnosis to art initiation, grouped by diagnosis year. While things have improved over time, improved over time. Even among those diagnosed after 2019, 22.7% waited more than 2 months to start treatment, ARV. In contrast, when surveyed, more than half of PLHIV said they wanted to start treatment either on the same day of diagnosis or within 1 week. Their reasons included waiting to maintain their health, prevent other illness, and reduce their viral loads as quickly as possible. This data has fueled CBO's-led advocacy for early ART initiation. In 2025, the Japanese Society for AIDS Research launched a new early treatment implementation committee, which includes CBO representatives as full members. Finally, let me talk about recent developments toward institutionalizing CLM in Japan. Until now, CLM-like activities have existed, but they are not reflected in official policy. However, in 2025, the National AIDS Prevention Guidelines were revised, and for the first time, monitoring was explicitly included. This was a direct result of advocacy from community groups. But the key question remains, will this monitoring be community-led? We are now at a critical moment. The next step is to ensure that CLM is fully integrated into national policy and that sufficient sustainable funding is allocated to support community-led efforts. To summarize, CLM has not yet been institutionalized in Japan, and its importance is still not widely recognized, even among experts and civil society. Yet, to truly end the epidemic, we must adopt a person-centered status-neutral approach. This required expanding access to testing, scaling up PrEP implementation, ensuring timely access to treatment, and eliminating stigma and discrimination. The case studies I have shared in this presentation reflect early steps towards such an approach, as they showed how CRM practices are already contributing to more inclusive and person-centered HIV responses in Japan. CBOs are ready and committed to leading the way through monitoring and advocacy. So this is my final slide. From an international perspective, gatherings like today's symposium are extremely valuable. Learning from global CRM practices will help us shape effective models for Japan. The initiatives I introduced today have mainly focused on MSM and people living with HIV. Due to budget and structural limitations, outreach to other key populations remains limited. That said, grassroots efforts are actively being carried out by CBOs representing different key populations despite limited funding and resources. Also, due to time constraints, I could not cover our stigma monitoring activities today. However, I'd like to note that the Futures Japan project is currently evaluating stigma experienced by people living with HIV. In closing, I want to thank everyone who contributed to this report. That concludes my presentation. Thank you very much.